I think we'll get started. So here's the number 87759. I'm going to stop sharing now and tell you a little bit about Dr. Mayson, whom we're very, very lucky to have speaking to us today. Dr. Mayson did his undergraduate at Tufts University and then medical school at Memorial University in Canada. He did a preliminary year at St. Vincent in Massachusetts, and then did his neurology residency at Mount Sinai in New York, where he also did his cardiovascular disease fellowship. He's been at Georgetown since 2014. We in the neuro ICU are very, very happy to work with Dr. Mayson and his colleagues. And while he's here, he's served as the Neurosonology Program Director and also helps the Program Director in the Global Health Track for Neurology. He is Medical Director of the C61 Neurological Unit and has been a site PI on several national and international trials. So he's going to talk to us today about the acute management of ischemic stroke. So thank you.
Thank you for the introduction. So we'll basically be talking about acute stroke, and I wanted to kind of do a bit of an overview about of thrombolysis and thrombectomy. Talking about just some of the stuff that I assume a lot of you folks already know in terms of sort of what we do and probably some of the trials supporting what we do as well. But also I wanted to get into some of the newer literature and sort of how things have evolved and seem to continue to evolve in terms of our ability to treat patients in the early acute window for stroke.
Why don't we have you share your screen?
I thought I was sharing.
Yeah.
I mean, you can't see it?
I can. Oh, I can now. Okay.
Okay.
Great. Thank you.
Sure. Sorry. All right. So we'll talk about the thrombolysis for patients presenting within 4.5 hours of stroke onset. We're going to talk about the current data on thrombolysis for wake-up stroke, which is an evolving area. And we'll also touch on the role of Tenecta Place, which we are not currently using for acute stroke, but it's gradually gaining more widespread adoption. And there's a number of different studies that are continuing to evaluate its role. We'll go through thrombectomy in the early and then the late time window, and then I'll actually do a little sort of plug for telestroke at the end. So ischemic stroke affects 750,000 folks a year in the United States. It's the number 5 cause of death and number 1 cause of disability. This is a map from CDC looking at death rates in adults by county due to ischemic stroke. And you can see there's a increase in distribution of patients suffering from ischemic stroke in the southern and midwestern portions of the United States. We don't know exactly why that is, and there has been multiple theories that have been proposed, some including diet, disproportionate number of vascular risk factors in that population, increased smoking rates, but seems to be a reality. And if you look at sort of the upper, right-hand portion, you can see that parts of Southern Maryland and Virginia and the District of Columbia are also have a higher incidence of stroke and are essentially part of this sort of the tail end of this stroke belt is what we have termed it. Stroke occurs when you have a thrombus forming or embolus lodging in one of the cerebral blood vessels in the brain, affecting either large, small, or small vessels. You have sudden loss of brain function that occurs not long after vascular occlusion due to energy failure. And that presents with hemiparesis, aphasia, neglect, hemisensory loss, to name just a few presenting syndromes. Early reperfusion has been the only proven strategy to significantly improve the outcome and reduce disability in stroke. So thrombolysis has been our mainstay since for probably about a little over 25 years now since the publication of the NINDS TPA trial. This was a large multi-center trial that was initiated out of the NIH that studied patients within the first 3 hours after onset of stroke. They randomized patients to either TPA or placebo within last known well time of 3 hours. So that can either be when the stroke initially occurred or when they were last seen well prior to the stroke if the actual onset of the stroke was unwitnessed. And their outcome that they looked at was a global outcome measure of disability, one of the components of which was the modified Rankin scale, which is used as the primary outcome in almost all of the major TPA and endovascular trials. So I just want to touch on what that is briefly. It's a quantitative measure of disability. So it's an ordinal scale that goes from 0 to 6, and patients with a 0 have no symptoms. 1, no significant disability, but they do have some symptoms, or it could be, may call it sort of minimal disability, mild disability. And it increases in the degree of disability as we reach 6, which is death. Patients in the 2 to 3 range are still ambulatory, but have increasing amounts of disability. And 4 and 5 are non-ambulatory without assistance. And those patients require a tremendous amount of assistance from others. The NINDS TPA trial was ultimately a positive study. They found that patients who were treated with TPA were 30% more likely to have minimal or no disability at 3 months, resulting in an absolute increase in 13% of patients who had minimal or no disability, so that modified Rankin score of 0 or 1 relative to placebo. This was the first trial that proved the efficacy of TPA. There had been a number of trials that had been performed in the 80s and the 90s that had failed, that were more broadly inclusive, had wider timeframes, included patients who were potentially at higher risk for developing hemorrhagic complications. Nonetheless, within the trial, there was about 6% of patients who developed what was termed a symptomatic intracerebral hemorrhage, 6% more patients than in the placebo arm. Those patients were included in the final outcome data. So that 13% was, of course, inclusive of those patients who had hemorrhagic transformation as well. The TPA window was extended out to 4.5 hours of last known well by the ECAS-3 trial, which was published in 2008. And they basically studied patients in the 3 to 4.5 hour window. Patients who were treated with TPA were 15% more likely to have minimal or no disability at 3 months. So again, modified Rankin 0 or 1. And that resulted in about a 7% increase, 7% absolute increase in the number of patients who had that favorable modified Rankin score. And there was also, again, a statistically significant increase in intracerebral hemorrhage. So I think it's worth kind of talking about the risk and benefit of TPA a little bit more, because it does have a relatively narrow therapeutic index. There is this devastating complication of intracerebral hemorrhage that all of us who treat a lot of stroke have seen occur. And so I think this sort of graphic on the left does a nice job of sort of demonstrating the risk benefit of TPA. In the initial, this is data from the first within 3 hours, patients who were treated within 3 hours of last known well. So basically out of 100 patients in that NINDS trial, 13 patients in the dark green figures have little to no disability. But subsequent studies that have analyzed both the data from the NINDS trial as well as larger data sets, prospective data sets for TPA administration have shown that as much as a third of patients may benefit to some degree with a reduction in their disability, though they don't achieve that little to no disability outcome. On the other hand, in the initial NINDS trial, we found that 6% of patients had early worsening due to hemorrhage. And they used a more broadly inclusive but less precise and probably less clinically relevant definition of intracerebral hemorrhage, which was that patients had to be felt to have had a clinical worsening that was secondary to intracerebral hemorrhage. Subsequent trials, including the ECAS-3 study and the endovascular studies and other studies of thrombolysis, have used a different assessment of what is a symptomatic intracerebral hemorrhage, which would be a 4-point worsening in their, defined as a 4-point worsening in their NIH stroke scale associated with it, intracerebral hemorrhage. So their clinical exam has to get significantly worse in association with the intracerebral hemorrhage. And that is more closely associated with patients who ultimately end up with a worse outcome as a result of receiving TPA. So that number shrinks from about 6% based on that earlier definition of intracerebral hemorrhage down to about 3% of patients who are worse or severely disabled, demarcated by the red figures in the bottom of the panel. What is an inexorable truth in stroke, and as far as I am concerned, always will be, is that time is brain. For every 15 minutes that we accelerate the administration of TPA, patients have a 4% greater odds of walking out of the hospital at the time of discharge rather than going to a facility, 4% lower odds of suffering a complication of intracerebral hemorrhage, and 3% greater odds of being discharged home. If you look at the panel on the right, it shows you how quickly the sort of risk benefit, the risk it comes to outpace the benefit as we get out past that 4.5-hour window. If you treat a patient really early on within the first 60, 90 minutes, just subjectively, very often you'll see fairly impressive outcomes. This patient are recanalized in the context of having a lot of remaining salvageable tissue, and that sort of perceived benefit becomes much less apparent as they get closer to that 4.5-hour kind of endpoint. And that's pretty consistent with the data that we've seen as well. When we assess an acute stroke patient, the most important thing is what their last known well time is, or the stroke onset. Their blood pressure is also important. Elevated blood pressures are associated with increased risk of hemorrhagic transformation. And so that needs to be addressed and modified. If the patient has a blood pressure over 185 on 110, for example, prior to TPA, we need to bring that down to allow for TPA administration. Glucose is the only lab that's actually required at this point in time. We cut out some of the other labs looking at sort of patient's platelets or their coagulation if we have no history of the patient having been on anticoagulants and no reason to suspect that those would be elevated. An NIH stroke scale is performed on every patient, which is, you can see on the panel on the right, is an example of an NIH stroke score. And on this, in the scale, basically, we evaluate multiple different components of the patient's physical exam that are known to be features of stroke, with an increasing score being consistent with an increasingly symptomatic and thus increasingly disabling stroke. CT scan is critical to rule out hemorrhage, and as we'll talk about later on, we also routinely perform a CT-ACT perfusion to evaluate for a large vessel occlusion. Because time is so critical, there's been a lot of emphasis through the American Stroke Association, JCO, and others in order to try to make the process of evaluation and administration of TPA as quick, and efficient as possible without compromising safety, knowing that the medication still does have this devastating complication of intracerebral hemorrhage. But we have, as you can see, these are pretty tight timeframes. It was not so long ago when I finished training that TPA was expected to be administered within 60 minutes, and we've cut that time back to 45 minutes. And all the rate limiting steps are expected to try to be, or their goals set to try to accomplish them as quickly and efficiently as possible. We have a stroke meeting our stroke coordinator holds once a month to discuss our goals, how we're doing, how we're accomplishing the goals, what other things we can do to improve administration of TPA and thrombectomy and enhance our delivery of stroke care in general, with the main focus continuing to be optimization of our times to TPA administration. So what do we do with patients who are outside of this early window? Well, TPA administration in patients who are suffering wake-up stroke was not possible up until the last few years. We did not have any sense of when the actual stroke was occurring. The assumption was that if they went to bed at 8 o'clock last night, that stroke could have occurred minutes from when they went to sleep. And thus, if you were administering the patient TPA, when you saw them in the morning at 9 a.m. in the emergency department, well, they were only an hour from waking, the stroke could have very well occurred right after they went to sleep, and thus they'd be, well outside of our 4.5-hour window. But as our understanding of stroke care has evolved and our imaging tools at our disposal have evolved, different investigators have looked into what tools we could potentially use to try to treat some of these patients. Because we know that patients who are presenting with a wake-up stroke could very well have had their stroke within minutes of waking, and probably a lot of folks do. It sort of stands to reason that not being able to move your extremities, that you may detect that as you're during sleep, and that could potentially wake you up. Obviously we don't know that for sure, especially on a case-by-case basis. One of the tools that was and approaches that had been suggested to treat wake-up stroke is using imaging essentially as a proxy for time, right? So what we know is that in the MRI, for acute stroke, our two sequences that we probably care the most about, that we spread the love around, but the two that we care the most about would be diffusion-weighted imaging, which is what you see along the top in this panel here, which shows us evidence of an acute ischemic stroke. And what happens with acute ischemia is that you have loss of fairly quickly loss of glucose, loss of oxygen, reduction in ATP, and then shutdown of your sodium potassium ATPase pumps, which affects the diffusion of water molecules. And when that occurs, as the water starts to move into cells, there's a reduction in the random movements of water molecules outside the cells, and that's picked up on our diffusion-weighted imaging, really within minutes of an acute stroke. On the other hand, FLAIR shows us an increase in the water content. So as cytotoxic edema develops in the context of stroke over time, the FLAIR changes only become apparent as we hit about 4.5 to 6 hours. And so what was proposed in the wake-up trial after a number of preclinical and early clinical studies, and wake-up trials are phase 3 randomized controlled trial, was to basically use this mismatch, right? And so if you look at the panel on the right here again, if you look at case A, you can see there's diffusion restriction representing acute stroke in the basal ganglia on the right, but nothing on FLAIR. In the B panel, diffusion restriction in the right frontal cortex, nothing on FLAIR. And so because we know FLAIR will not turn positive until 4.5 plus hours, the hypothesis was that we could use this mismatch basically to try to identify patients that are effectively within the 4.5-hour window. And so what they did was randomize patients who have this mismatch profile, so acute stroke, but appears based on MRI imaging to be within 4.5 hour window, within the 4.5 hour window, or at least of acute onset in the early phase. Randomized 503 patients to alteplase or placebo in a 1-to-1 fashion, similar treatment dose as we would treat patients who are within the 4.5 hour window, and the same outcome measure of the modified Rankin of 0-to-1. And the results were similar. The data was eventually published in the New England Journal of Medicine in 2018. And what they found was that patients had an absolute increase in the number of patients with minimal or no disability of 11.5%. They did not find a statistically significant difference in the rate of intracerebral hemorrhage, although there was numerically a greater number of patients in the alteplase group that had intracerebral hemorrhage. And so as a result of this, we're now treating patients. The guidelines have evolved and have suggested that we only have a single randomized trial, but have suggested that the guidelines have suggested at this point that it would be reasonable to potentially treat some wake-up strokes, carefully selected wake-up strokes, using this MRI mismatch profile to select patients who might benefit from TPA. And so we've started to do that at Georgetown, although I have to say the numbers that we've actually treated have been quite small. It's more often over at Washington Hospital Center, because they have a larger number of TPA cases, and they also perform MRI on patient arrival. They have treated a fair number of patients using data from the Wake Up trial and using this approach. So I'd like to move on and talk a little bit about Tenecta Place, or TNK for acute stroke. So Tenecta Place is a genetically modified variant of alteplase, which is native TPA. And the modifications allow for an enhanced affinity to clot-bound fibrin. The half-life is also extended from 4 minutes to 22 minutes. And therefore, the Tenecta Place is actually administered as a single bolus rather than a push followed by a 1-hour IV infusion with alteplase. Number of randomized trials, phase 2, were performed looking at Tenecta Place versus alteplase, most of which found equivalency, and one found benefit to using Tenecta Place over alteplase. Before a phase 3 trial in 2017 was performed in Norway called the NORTEST trial, where they randomized over 1,000 patients to TNK versus alteplase versus TPA. And they used a similar outcome measure, primary outcome and safety measure, and found that there was non-inferiority to the use of Tenecta Place versus alteplase for acute stroke presenting within 4.5 hours of last known well. There's some appeal to Tenecta Place in clinical practice. The being able to administer it as a single push, and its shorter preparation time makes the administration more simple. For example, one of the issues is that we always have to place 2 IVs in patients, because the infusion of alteplase can't be interrupted, and patients obviously need IV access for imaging procedures, medications. That is not a requirement if you use Tenecta Place, which can be administered over a push of 5 seconds or so. And you also don't have to wrangle up an IV pump as well. And so you potentially shave off some time to TPA administration. In addition, it also simplifies intra-hospital transfer, because you're no longer having to transfer a patient who's actively getting actively getting an IV infusion of alteplase. And some recent study had shown that the door to groin puncture time could potentially be as much as 15 minutes less in patients who received alteplase and Tenecta Place in comparison to alteplase. In addition, at least currently, it's less expensive, though they're both manufactured by the same company, Genentech, and I'm sure that as Tenecta Place becomes more widely used, that may change. What What's one thing that I'd like to mention is just over at Washington Hospital Center, they're actually doing a pilot looking at Tenecta Place in place of Alteplase for treatment of acute ischemic stroke. Running it essentially as a pilot study. What they're essentially doing is for all patients who are presenting with an acute stroke, they are administering Tenecta Place in lieu of Alteplase to patients. And they'll be continuing to monitor those patients over the subsequent months and years. In addition, there's also multiple phase 3 randomized controlled trials that should be published in the next 2 to 3 years, looking at Alteplase within the early time window, Tenecta Place in the early time window versus Alteplase in the for wake-up strokes as well, looking at Tenecta Place versus Alteplase. So it'll be interesting to see those results come out. I anticipate that if the pilot's successful over at Washington Hospital Center, and as we get more data about this medication, I think there's a reasonable chance we'll eventually see adoption of Tenecta Place at Georgetown as well. So for the second half of the talk, I wanted to talk about endovascular therapy in acute ischemic stroke. So this is a case that I saw a few years ago. So I was notified that there's a 68-year-old female with acute onset of right-sided weakness, aphasia. She awoke normal, but during breakfast around 8 a.m., her husband noted her speaking gibberish. And by the time she got to the ER at around 9, she was being seen about an hour from her last known well time, which was 8 a.m. CTA showed a proximal left middle cerebral artery occlusion. How do we treat these patients? So this patient's suffering what we term a large vessel occlusion. So that's an internal carotid artery, MCA, ACA, or basilar artery. And what happens is you have a thrombus that lodges in your M1, the proximal portion of your MCA, leading to a large penumbra of hypoperfused brain tissue and initially a small but ever expanding core that will expand as potentially to meet the size of the penumbra. The expansion of the penumbra is determined largely by collaterals, which are really variable among patients. Some patients have such poor collaterals that their core will expand to meet the penumbra within an hour, 90 minutes of vessel occlusion. Others can hang on for up to 24 hours, and potentially some even longer than that. Well, they continue to the core will continue to expand. TPA, unfortunately, is not that effective at opening large vessel occlusions. It's more effective if the patient's treated early, if the length of the actual large vessel occlusion is short, just a few millimeters. TPA can often lyse those thrombi. But as thrombi increase in length, which many of them are 8 millimeters plus, you'll almost never recanalize a vessel with thrombolysis alone. And we know that these large vessel occlusions, because such a huge amount of brain tissue is involved, that these are devastating strokes, and we know that their prognosis without revascularization is generally poor. So some of the devices potentially that we can use in endovascular treatment to open up vessels include the Mercy retriever, which is not in use anymore. It was used in the early 2000s. It had sort of this corkscrew-like appearance. It's deployed across the clot, and while it attempted to interdigitate into clot, unfortunately, it didn't grab onto it well enough, and a lot of times the recanalization was unsuccessful. More recent technology includes an aspiration catheter, which you see here, and the stent retriever, which was used most commonly in the thrombectomy trials. In 2012, 2013, there were 3 thrombectomy trials that were published, all of which failed, unfortunately. They showed no clear benefit over standard medical therapy. And I think most of that is secondary to technology, although some of it's also due to the trial design and lack of inclusion of using a CTA as a selection, part of the selection criteria. So there were a number of patients who did not have large vessel occlusion that were included in the trials. But in 2014, 2015, we actually had 5 randomized trials, all of which were published in the New England Journal, demonstrating efficacy for this approach. So the first one was Mr. Clean, which was published in 2014. They randomized 500 patients to endovascular treatment versus usual care, including TPA if they were eligible. The inclusion criteria included an acute ischemic stroke. They had to have an anterior circulation large vessel occlusion. So that was a terminal ICA occlusion, internal carotid artery occlusion, or proximal MCA occlusion. They had to, groin puncture had to occur within 6 hours for endovascular therapy. They had to have at least an NIH stroke scale score of 2. And the primary outcome was the 90-day modified Rankin. And this is the outcome from that study. There was a common adjusted odds ratio of 1.67, which was statistically significant for reduction in disability and shift from the control arm versus the intervention arm to less degrees of patient disability. Parenchymal hematoma was one of the more common and devastating complications, but the rates were similar between patients who received thrombectomy and those who did not. What was more likely and statistically significant was new strokes that occurred in a different vascular territory, presumably due to some thrombus falling off during the thrombectomy, during use of the stent retriever, or potentially thrombus forming on the catheter itself and going into a different vascular territory. And this is the summary of the early endovascular studies from a meta-analysis that was published back in 2016. After Mr. Clean was published, which is my favorite named trial, in 2015, there were 4 other trials that were terminated early for efficacy. And endovascular therapy led to reduced disability, and the number needed to treat overall in order to reduce a person's disability is only a little over 2.5. In terms of acute management, I'd just like to kind of loop back around to our patient, who's a 68-year-old female. She had a normal head CT and proximal MCA occlusion on CTA. She received TPA because she was within the 4.5-hour window and didn't have contraindications. They called our on-call stroke team, which was me, and ultimately I notified Dr. Stemmer, Dr. McCullough, our endovascular specialist, who came into the hospital. Patient was brought into the angio suite and intubated, and thrombectomy was performed using stent retriever device. I don't know if the video is going to play. I'm going to try it, but this is a video of showing the deployment of the stent retriever. The patient's already had groin puncture. A microcatheter has been threaded up across up through the carotid and is crossing this thrombus. And you'll see in this video that the microcatheter will be removed, and that deploys the stent retriever, leading to recanalization of the vessel, allowing for some downstream reperfusion. They'll actually maintain the deployed stent in the vessel for about 5 minutes before removing the thrombus under balloon occlusion or aspiration. And this is the before and after picture for our patient. So you can see the middle cerebral artery on the left was occluded, and on the right appears to have since been recanalized. What about thrombectomy beyond the 6-hour time window? This was actually the first patient in the sort of 6 to 24-hour window that I had the privilege to treat. And he was a 48-year-old fighter pilot who went to bed normal at around 9 p.m. and then awoke the following morning at 6 a.m. with difficulty speaking and a right hemiparesis. I saw him using our video telestroke system. He had an NIH stroke scale score of 7, losing points for his aphasia, facial droop, and right-sided weakness. It was about 12 hours from last known well by the time we initially evaluated him. So not a candidate for TPA, but potentially a candidate for treatment within the extended time window. So since 2018, we've been performing thrombectomy out to 24 hours from last normal. On the left is the diffuse trial. On the right is the DAWN trial, which are both large randomized trials looking at thrombectomy after 6 hours. They both used perfusion imaging in order to select patients. I'm just going to focus on the diffuse trial, as this trial's closest to our clinical practice, but both trials demonstrated overwhelming efficacy for using this perfusion imaging to select patients in the extended window. So this is a multi-center randomized open label trial with a blinded outcome assessment. Patients in the 6 to 16 hour range from last known well were randomized to thrombectomy or usual care for anterior circulation, large vessel occlusion. They were not treated with TPA since none of them were within 4.5 hours. And on the right, you can see an example of our CT perfusion imaging. The green, the tissue denoted in green is their penumbra, and their core is denoted in pink. A similar, late window study, DAWN, which I mentioned, reported positive results in 2017, and Diffuse 3 was held for early interim analysis, then halted for efficacy. And this is the outcome. They were looking at a shift analysis of modified Rankin, the modified Rankin scale. So how much more likely were patients to have reduced disability when a thrombectomy was performed using the selection criteria? And again, it was even more impressive efficacy, which initially was surprising given that we're talking about patients who are in a later time window. But using perfusion imaging, they're selecting patients very, very carefully who have great collaterals, large salvageable penumbra, small core. And so they were patients who were appropriately selected for this trial to be most likely to benefit from thrombectomy, as they had quite a large amount of salvageable tissue. Perfusion imaging was not used in very many of the early studies within 6 hours, and were generally more broadly inclusive in that regard. So I think probably explains the reason for such a robust benefit to treatment in the extended time window relative to the early time window. The rate of symptomatic intracerebral hemorrhage was not statistically significantly different, and the rate of death, this is actually the first trial that showed a decreased rate of mortality rate with any acute stroke therapy with a barely statistically significant p-value. So for thrombectomy in the 6 to 24 hour window, we basically have the same selection criteria with the addition of MR or CT perfusion. So if we go back to our patient, so he's our fighter pilot, right-sided weakness, aphasia. We're concerned that he has a large vessel occlusion because of the combination of his presenting signs, aphasia, right hemiparesis. Most common way to present with those findings would be due to a left MCA occlusion. He was not a TPA candidate, obviously because he's late window, and CT, CTA, and CT perfusion were performed. So this is actually his non-contrast head CT. We can actually see he already has some early ischemic change in the Sylvian fissure along the insular ribbon and medial temporal lobe on the left side. His CTA shows a distal M1, occlusion, so still proximal MCA occlusion in the distal first segment of the MCA. And this is his perfusion imaging. So if you look at the perfusion map on the right for patients who have a Tmax greater than 6 seconds, so this is patients who in preclinical data and early clinical trials looked to be most, this imaging profile was most consistent with salvageable penumbra. There was about 120 cc's in that group. And in patients who had a reduced cerebral blood volume, which is most associated with core, he had about 25 cc's. So there was about almost 100 cc's worth of brain tissue that is potentially salvageable with a mismatch ratio of 4.8. Just as a side note, these maps are automatically created using, I understand the software was developed using sort of AI and machine learning, and evaluating, and basically is run on top of a sort of CT perfusion in order to sort of develop our more easy to interpret maps. And this software was used in both of the extended window thrombectomy trials. So if we go back to our case, we got a 48-year-old male with acute onset of aphasia and hemiparesis. He was 12 hours from last known well. He does not have any baseline disability, which makes him a good candidate for thrombectomy. He has significant disabling deficits, a small core on his head CT as well as the CT perfusion, a proximal middle cerebral artery occlusion, and ultimately, because his CT perfusion showed that he had a large perfusion deficit and small core, despite being so far out from his last known well, he ultimately was felt to be an excellent thrombectomy candidate. We transferred him over to Georgetown using our helicopter, and you can see his MCA occlusion. This is an angiogram from his actual case. In the lateral view, you can see there's quite a large. You don't see clearly see the vessels of the anterior cerebral artery. You really don't see filling of the middle cerebral artery vessels. Dr. Stemmer passed a microcatheter across the thrombus, and in this case actually used an aspiration catheter, I believe, instead of stent triever in order to open the vessel. Essentially, apply the idea is that you pass the aspiration catheter across the clot, apply suction, and under balloon occlusion, the thrombus is removed. Dr. Stemmer will often use this as prior to using a stent retriever, in that there's good data to support its equivalency to the stent retrievers, and it is a little bit faster and easier to perform. If unsuccessful, stent retriever, or if the vessels are further downstream that are occluded, stent retriever is often favored. And this is the before and after angiogram. You can see on the left that fairly significant left MCA occlusion. And in the right panel, you can see we have now opened up vessels in his middle cerebral artery territory that were previously occluded. And this is the lateral view. This is what the thrombus actually looks like at the end of the aspiration catheter. And this is what his MRI ultimately looked like. So we actually, thankfully for him, he had excellent collaterals, was able to maintain a pretty large of hypoperfusion for a long time without significantly expanding his core infarct, and we were able to recanalize him. And so the stroke was actually limited to essentially the territory that we saw on his initial CAT scan. 9 months later, he had a mild sensory abnormality in his right hand, and the etiology was felt to be secondary to PFO. He had a pretty large PFO that was closed, no other risk factors for stroke. This is a picture he actually gave me of him flying near Whidbey Island, from Whidbey Island, I guess, in the Cascades out in Washington State. He was hoping to return to a couple more years of flying. I think it sounded like last I talked to him that it was unlikely to happen, but he was hopeful that he would eventually be able to fly commercial planes or kind of larger cargo type planes with the military. One last sort of little piece that I wanted to touch on was just our telestroke capability. This is sort of similar to one of the carts that we use. And we have telestroke carts that are stationed at multiple MedStar spoke sites in both MedStar South and North. And if a emergency medicine provider has a patient who's presenting with acute stroke symptoms, they'll call MedStar Transport, who will alert us. And we will take a look at the patient using the telestroke video cart in order to assess their clinical exam, dig a little deeper into their history, and review. We were also able to review their imaging remotely as well. And so we're able to provide a service to our other sister hospitals to help them with providing as top-notch stroke care as possible, and advising them on TPA, thrombectomy, and other emergent management in stroke. This is our hospitals in MedStar South, from which we get most of our patients. Georgetown and Hospital Center are the two core hubs, and patients are often transferred from Montgomery Medical Center, Southern Maryland, St. Mary's, as well as some of our non-affiliated surrounding hospitals for higher level of care, intervention most commonly. So in summary, the candidacy for thrombolysis continues to expand and evolve. It's obviously been pretty slow progress. It was, almost, over 20 years without any great change in how we were managing patients with thrombolytics, but we seem to be on the path to be able to treat patients with wake-up stroke and achieve similar results if they have a favorable imaging profile. We also are keeping our eyes open to kind of see how things go with the hospital center pilot studying Tenecta Place. In the second part of my talk, we talked a little bit about endovascular intervention as a life-saving and life-altering intervention. We are able to treat patients within the 6-hour time window, and now out to as far out as 24 hours. Ultimately, though, early identification, appropriate use of imaging allows us to greatly reduce time to treatment, and since time is and probably always will be brain, improve patient outcomes.